morning, everyone. Thank you all for joining in this session. Today, I'll be presenting a swallowing assessment and management plan for Mr. Lamb, who we intend to discharge home soon. Through this presentation, my goal is to ensure that we have a shared understanding of Mr. Lamb's needs and a clear multidisciplinary collaboration for effective management. Mr. Lamb is a 72-year-old male presenting with swallowing difficulties following a right ischemic stroke. At home, he lives with his supportive wife and has a close-knit family with children visiting regularly. Previously, Mr. Lamb was active and sociable. He enjoyed cooking, sharing family meals, and meeting friends weekly for lunch. He and his wife are concerned about how his dysphagia will impact his daily routine after discharge, although his strong motivation to return to his previous lifestyle displays a key asset for rehabilitation. Our management will ensure addressing his medical safety alongside his family involvement, social participation, and emotional well-being. To confirm Mr. Lamb's swallowing assessment and diagnosis, critical gaps need to be addressed. These include understanding his previous medical history, particularly if any anatomical impairments are present, as this could alter the current neurological cause of his oropharyngeal dysphagia. This information would be crucial to ensure that our understanding is accurate and targeted, further guiding his management approach. Additionally, while we are aware that Mr. Lamb's swallowing disorder is associated with his stroke, more details about the location and extent of the lesion are essential to determine the likely nature and type of dysphagia. For instance, whether it stems from muscle weakness due to damage in his motor cortex or sensory or cortical impairments due to cerebral cortex damage. This information would also clarify his current cognitive and communication abilities, such as attention, ability to follow instructions, and the degree of his dysarthria, guiding our strategies for safe and realistic management of his dysphagia. During the clinical swallow evaluation, Mr. Lamb was alert and oriented and able to follow 1 to 2-step instructions with occasional repetition, though his memory appeared somewhat reduced. On cranial nerve examination, it was observed that Mr. Lamb's jaw deviated to the left with weak and asymmetrical resistance to opening, indicating trigeminal motor nerve impairment. This suggests that he may have weakness in his muscles of mastication and submental muscles, reducing his efficiency of chewing before swallowing and airway protection. He also had a reduced sensation on his lower left face, implying trigeminal sensory nerve damage, which could reflect a decreased awareness of bolus size, shape, and temperature inside his mouth on the left and result in discoordinated swallowing. While taste was preserved, a left facial droop was noted, indicating facial motor nerve impairment, which may compromise his left labial seal and oral bolus control. Mr. Lamb further presented with impairment of the pharyngeal plexus, involving the motor and sensory glossopharyngeal and vagus nerves, as he showed asymmetrical soft palate elevation, a somewhat breathy and weak voice quality, and failed the cough reflex test. This raises concerns about weakness in his pharyngeal muscles and silent aspiration. Oral trials with thin fluids and yogurt showed that Mr. Lamb had sufficient bolus retrieval and containment, with no anterior spillage. He was able to clear oral residue after multiple swallows, although he reported a sensation of food sticking in his throat. Importantly, there was no overt coughing during the trials, though he and his wife reported frequent coughing during meals at home. Evaluating these findings and their implications proposes dysphagia due to a muscle weakness following his stroke, as weakness was evident in his jaw, facial, and pharyngeal muscles, contributing to impaired airway protection and inefficient swallowing. An instrumental assessment using a videofluoroscopic swallow study was warranted for Mr. Lamb, given that he reported a sensation of food being stuck in his throat. A VFSS would be essential to objectively assess the strength of his pharyngeal muscles and degree of pharyngeal clearance for effective swallowing. Additionally, as Mr. Lamb failed the cough reflex test in the acute hospital, it would be important to use VFSS to determine the presence of silent aspiration, which could provoke long-term consequences such as malnutrition, aspiration pneumonia, and a decreased quality of life. VFSS analysis revealed a penetration aspiration score of 7, implying that material entered the airway, passed below the vocal folds, and was not expelled despite mild effort. This reflects a significant risk of aspiration and emphasizes the need for targeted management. One key impairment observed on the VFSS, particularly when Mr. Lamb was swallowing liquids, included reduced pharyngeal constriction demonstrated by an incomplete clearance of the bolus through his pharynx. This produced large amounts of residual pooling, increasing his risk of aspiration and requiring multiple swallows to clear the material. A reduced and delayed epiglottic deflection was also visible, compromising complete laryngeal closure and exposing his airway to aspiration. Reduced upward and forward movement of the larynx and hyoid bone was noted consistently throughout his swallows and resulted in limited airway protection and opening of his upper esophageal sphincter, increasing his chances of residue and aspiration during swallowing. Reduced and delayed epiglottic deflection, as identified in the VFSS, can be addressed using the Mendelssohn maneuver compensatory strategy. This technique involves the patient consciously prolonging the elevation of their larynx during a swallow by pausing mid-swallow when the larynx has reached its highest point of elevation. This subsequently increases epiglottic inversion and the width and duration of the upper esophageal sphincter opening, improving airway protection and allowing more time and space for the bolus to flow into the esophagus. This strategy primarily addresses Mr. Lamb's swallowing safety, as by enhancing laryngeal elevation and closure, his airway is better protected and risk of aspiration is reduced. It also addresses his swallowing efficiency through facilitation of bolus passage into the esophagus and a reduction in pharyngeal residue, which was requiring multiple swallows and creating a sensation of food being stuck. Given Mr. Lamb's high motivation and ability to follow simple instructions, the Mendelssohn maneuver would be a practical strategy to incorporate, which directly targets his muscle weakness and provides immediate functional benefit. For Mr. Lamb's rehabilitation, the chin tuck against resistance exercise is recommended, specifically targeting his suprahyoid muscles, which are responsible for addressing the reduced upwards and forwards movement of the larynx and hyoid bone. This exercise involves prompting Mr. Lamb to tuck his chin against a small resistance, such as a rubber ball or rolled up towel, and squeeze firmly for 3 seconds, repeating the exercise 30 times to strengthen his muscles. Evidence shows that by strengthening these muscles, elevation and anterior movement of the larynx and hyoid bone is improved, facilitating airway protection and reducing aspiration risk. Swallowing efficiency is also targeted through reduced pooling of the bolus in the sinuses. This exercise is practical for Mr. Lamb as it can be performed in a seated position, requires minimal equipment, and is less fatiguing than traditional shaker head lift exercises. The Mendelssohn maneuver compensatory strategy is supported by abundant evidence, particularly a randomized control trial conducted in 2012, which stated that this strategy improved duration of hyoid elevation and excursion and average width of upper esophageal sphincter opening following 2 weeks of treatment. Though functional results were not analyzed, the authors speculated that the improvements would result in less pharyngeal residue and fewer instances of penetration and aspiration. A systematic review conducted on the chin tuck against resistance rehabilitation exercise in 2023 also showed a positive effect on improving swallowing safety, oral intake ability, and psychological condition when compared to no exercise intervention and shaker head lift exercise. Findings revealed a reduced risk of penetration aspiration and improved quality of life of the stroke patients, although recommended further exploration of training dose and efficiency to establish universal standard parameters. Short-term considerations for Mr. Lamb include ensuring safe oral intake while minimizing aspiration risk, involving collaboration with the dietitian to help tailor food textures and fluid consistencies that balance safety with enjoyment of meals. Input from nursing staff can assist in monitoring his tolerance and support with meal setup. Long-term considerations include ongoing speech pathology support for his swallowing and dysarthria management, collaboration with an occupational therapist to support his independent feeding, and referral to a neuropsychologist to help address his attentional and memory difficulties, which may influence his dysphagia. Providing education to his family can also ensure a shared understanding and support at home. This holistic approach will support both Mr. Lamb's immediate needs and his long-term aspiration, allowing a return to an active, sociable lifestyle.